So, welcome back, everybody, to the chatcast with Rachel France and Tom Waldron. So, today we're going to be talking about a topic that is often spoken about online and in the classroom regarding back pain and anterior pelvic tilt. So, we're going to be going into a little bit of our opinions on that topic and also some of the research, and then maybe a bit more of the nuances into this particular discussion. So what we'll do, Rach, is I thought a good place to start would be talking about what is the pelvis, and then you can segue that into what is an anterior pelvic tilt.
Yeah, I love simple, Tom. You know me, and I think sometimes you're not quite sure who the audience is, and we are so familiar with speaking to practitioners, and yet there is an audience out there who are the end user, the clients. So being mindful of that, and also sometimes by simplifying, it all makes more sense. So yeah, anatomically, the pelvis we think of in the middle of the body, but when you break it down into parts, um, uh, and I think I'm just sort of holding back here just a little bit because when we talk about anterior pelvic tilt and back pain, it's understanding the structures below and above as well. So, in simple terms, you've got your two ilia. So, as you see, Tom's got his in the background. We always have our skeleton friends here. Two ilia. You've got the pubis where they meet at the front, and we've got the, just turn him around, ischial tuberosity, which is these sit bones here. But of course, a key joint is the sacroiliac joint within which the two ilia, the sacrum sits. And often, I really enjoyed a phase of my studies, Tom, where I started to look at all the etymology of anatomical language. And it really helped me remember A, anatomical language, and B, the fascination of, oh, that's interesting when you go back to our ancestors and how they named body parts. So, sacrum is a sacred area of the body, hence sacrum, and that sacrum sits between the two ilia, which we think of as that is the pelvis, but also we think of it as the hips, and don't we? And often clients in particular think of the pelvis as the hip bones, maybe the bits they can feel at the front, which is our ASIS, anterior superior iliac spine. I won't go into too much detail, but just again, that sort of pelvis, hips, and then the bones that make them up, which I'm sure you can elaborate further on. But did I miss anything there, Tom? Do you want to elaborate? Because obviously, as we go through this, we'll probably talk more around other parts around the pelvis, of course.
Yeah, totally. Yeah, no, I think what I'd add in, especially for people who are maybe learning anatomy in their early stages of their career, or if you are a layman's person listening today. So the pelvis is the middle of the body, as Rachel said, and the pelvis is made up of four bones. So in the adult, so you have the two pelvic bones, which is what Rachel was pointing at. So you have a right pelvic bone and a left pelvic bone. We also call them hip bones. And the bottom of the pelvic bones, we call them sit bones or ischial tuberosities, but that's the part of the pelvis you typically sit on. And then you also have the sacrum and then you have the coccyx. So those four bones are functionally and anatomically part of the pelvis. And the pelvis is also a series of joints as well. So you have 10 joints in total that make up the pelvic girdle. And as we focus on primarily at the early stages of being a biomechanics coach, because the pelvis is the middle of the body and there are so many joints that connect the pelvis to other areas like the spine and the thighs, if there is any restriction in the pelvis, that may impact the body lower down or the body higher up the chain.
And I think that is a key point in probably the direction we're going to go in this entire subject, sort of linking or talking around an anterior pelvic tilt, which we'll talk about in a moment, and then the link to back pain, because we have to go beyond the pelvis. When we talk
Mhm.
about anterior pelvic tilt, the body does not work in isolation. It inadvertently, it will obviously influence all the joints above and below based
Mm.
on the way the body functions, the way it's connected, the law of gravity, and how the soft tissues move the bones around as well, right, Tom?
Yeah, definitely. Yeah. And I think it's important, like, as you say, when we talk about things like anterior pelvic tilt or posterior pelvic tilt, what we're talking about here is alignment. And I think what's really important to understand is that there's a difference between alignment and there's a difference between function. And they can definitely overlap. If you're not able to move in a particular plane, if you have a restriction, that may impact your movement or your performance on a level. But then there's obviously more to that story, isn't there, Rachel? So I think what would be great, Rach, is to go into next. So we've addressed what the pelvis is. We could talk more about that, but I think that's enough for now. But so can you give your take on alignment? So again, if there's someone here that's listening for the first time about alignment, what is alignment? And then how do we view alignment from the point of view of the pelvis?
Yeah, thanks for asking that. And I've been thinking about this a lot lately. I'm actually doing a talk on Saturday at a wellness festival with the
Cool.
question, can you do yoga wrong? And it brought me to this whole alignment of the body topic. And so I've had a career in movement for 3 decades. I've been involved in movement practice for 5 decades since I was very small. So I was from a dance background, and then becoming an exercise professional. Um, Everything was about creating lines within the body, and this was in relation to performance, so the aesthetic presentation of all of our dance arm lines being at the same point, and so 90 degrees off the shoulder, however you want to, parallel to the
Mm.
floor, for example, but also from the safety perspective. So when we position our feet under our knees, under our hips, to do a squat, for example, there is a safe alignment to stack the joints in what's known as that minimal tension point.
Mm.
So anybody who's listening, if you're able and willing and want to stand up, and if you stand and almost just let the arms hang beside you, and just rock slightly forwards and back through the forefoot and the heel, and you'll find a midpoint where you almost settle into an alignment that feels more comfortable and less tension. So if I was to lean forwards, there's more tension in the back of the body to stop gravity pulling me forwards, and vice versa. So that sort of minimal tension point has been taught in movement practices for many, many years. We need to be in a certain alignment, combined with the aesthetics of gymnastics, and creating common lines. So in my dance troupe, we all had to have the same kick height to, even if some could kick higher, we would all kick to the same height to look aesthetically pleasing in those kind of group performances. So I think there are two sort of aspects to alignment, and they're the two that I initially think around. So I don't know if you've got anything to add on to that definition of alignment, Tom.
Yeah, I think with alignment, it's from my view, alignment originates primarily in aesthetics or the arts. So dance, even like, or especially certain types of dance. So you obviously have ballet, but then you have contemporary dance, and yoga is obviously not necessarily a dance, but it's a movement practice. And I'm from the Pilates world, where again, we're looking for lines that look aesthetically pleasing. And there's nothing wrong with that. I think it's really cool to have different practices where you're looking for like certain outcomes. And it doesn't mean we can all achieve those outcomes based on our fitness level, but also based on our anatomical presentation. But I think that's totally fine to have that aesthetic preference because you have that in things like music and other things. So it's fine to have that with the body, I think. But then I think it's really important to then appreciate. So does aesthetics equal function and vice versa? And I think sometimes there's a correlation, there's a crossover, that it's not all just purely how things look. But then I think when you become a personal trainer, Pilates teacher, yoga teacher, and you have enough time with people, you start to notice that, oh, so and so hasn't got any pain. They move beautifully in their own way, but it's not in the textbook or in the manual that I'm looking at. And I think that can cause some initial confusion and maybe like a Kubler-Ross moment because it's like, well, where does my knowledge need to expand more, or like do I have to reevaluate my original training because what I'm seeing in practice is not necessarily what I was taught in a classroom when I was doing my diploma or my degree or whatever. So I think it's in my, where I've come to it with alignment is I think we can help people in a health point of view with alignment. I think there's loads of value in that. I think there's an aesthetic and artistic merit to it as well. But I also think it's then stepping out and appreciating that it doesn't mean that we all need to be in the same alignment just because we're the same species, if that makes sense from a health or performance point of view.
It
So I think oh, sorry, Rachel.
I'm just going to say, and I think just to sort of add into that, something that another powerful sort of part of my journey was then 10 years in care working with elderly and disabled bodies.
Mm,
I've had an Olympic high jumper, Paralympic high jumper, who had a club foot at birth and moves beautifully. And, you know, he's doing high jump on asymmetry. So again, the alignment through one leg is different to the other, you know,
mhm,
and it does bring about those questions as a movement teacher, in a variety of forms, but teaching other people how to move their bodies. It does become this dichotomy, doesn't it, between
yeah.
safe practice of alignment and then
Mhm.
freedom within your own physicality and limitations, doesn't it?
Yeah. Yeah, and I think I like what you're saying about the safe aspect because then that brings in other factors like what load are we in or what load are we using with certain alignments or volume of movement. So can someone tolerate that alignment for a certain period of time? And I think that's a nice way to bring in other elements. And so I think then what would be great then, Rachel, with that is so we're talking about alignment and all the different ways in which alignment threads in. There's obviously an emotional, mental well-being aspect to alignment as well. But when it comes to the pelvis, so I guess what I'd ask you is, do you believe there is an alignment that everyone should be in if they want to reduce the likelihood of pelvic or lower back pain?
It's a great question, Tom. And I think every individual has their I don't like the word perfect, but I think every individual has a perfect alignment to stack the body, pelvis obviously, in a way that um, has that minimal tension point with the joints above and below, that is good for their frame, but you have to then add in adaptions, history, medical history, lifestyle, which then complicates that perfect position. I guess my first response to your question is there isn't a uniform perfect alignment. I don't think there can be. And one of the things that I find myself saying more and more now is we are as different inside as we are on the outside. So if you
Mhm,
look around the classroom, who in the room looks exactly the same as you?
mhm,
Obviously, nobody. So then
mhm,
imagine inside their body, it's going to be the same. No two pelvis will be exactly the same, or even if they're as near as damn it the same.
mhm,
You then add in the variables of gluteal tone, hip flexor tone, neural tension, spinal curvature, natural posture,
mhm.
based on lifestyle. Um, then it makes it more complex. But I think there's kind of a yes no. No uniform individually, yes, but it's
Mhm.
never that simple
Mhm.
a measure. So
No, 100%. Yeah, and I think one thing I think about a lot is I've been getting my Anna, my illustrator I work with, we've been doing lots of pelvic illustrations the last couple of months. And one thing we've been doing is we've been making illustrations of a chimpanzee pelvis and then a human pelvis. So we're looking at the differences and it's really I've seen a lot of chimpanzee pelvises the last couple of months. And it's really cool when you look at evolutionarily the changes in alignment that's happened in our bodies over like 5 million years basically of being upright And I think, one thing which is also interesting is like, so we've evolved to be bipedal, we're evolved for upright locomotion, but we can only do that if we had a certain alignment in the pelvis. So this is where like alignment for me does bleed into function, because we know that the pelvic bones are in different positions in the human compared to the primate, and that's what allows us to stand on one leg, for example, when you swing another leg forward as you walk. And so I do think there is this interesting thing, like you say, about someone having like a quote unquote optimal or quote unquote perfect alignment for their body based on their own joint geometry and angles and everything like that, the depths of their hip sockets. I think that does exist. And again, it comes back to the same thing of that it's probably not going to be the same for me as it is for you. How you generate force coming out of a squat and what's the best position for your glutes and hamstrings to really fire is probably going to be quite different to mine. And then I think this is when it comes back to, so alignment does have relevance. It is important for performance and rehab and biomechanics, but then it still comes back to, so, but what alignments is better for that individual? Does that make sense?
100%. It's got to be with the human body and all the amazing systems that are out there to coach movement, assess movement, look at movement. Um, there's just so many variables. You have to contextualize certain questions. I think this comes back to the reason we're talking about this subject about anterior pelvic tilt
Mm,
and the link with low back pain. And the point being, when we read certain aspects, when people discuss this on social media, in blogs, in articles, we have to understand the context it's being presented. Somebody does a very quick, short 90-second reel on TikTok, Instagram,
mm,
um, the messaging, we need to understand exactly what they mean. They may be saying something to grab your attention, understandable in
mm.
a commercial world. But actually, when we go down into the nuts and bolts and the detail, are we getting that real that depth of understanding of what is being said? And that's where, again,
Yeah.
communication is very, very condensed now, and it can misfire or miscommunicate what's actually being said.
Yeah, absolutely, Rach. Yeah, and on that, so with your own studying and also your own experience as a practitioner, as a biomechanics coach, what's been your experience or your view on the relationship or lack thereof of anterior pelvis and back pain? So do you see it that when you work with individuals that might have back pain or lower back discomfort, that they do have a particular postural presentation in the pelvis? What's your view on that?
Um, and again, my experience is extremely limited, even across the decades I've been practicing. I always see that it's still very limited.
Mhm.
And the posture of the individual overall, I take with a slight, I'm interested, but I'm more fascinated by each area of the body and how that contributes with our biomechanical assessments. But in answer to your question, if I was to think retrospectively about posture, I've seen more of a link to a posterior tilt and back pain in terms of a protection posture rather than an anterior tilt. Maybe we should define anterior and posterior if
Yeah.
people are watching or listening. I'm not sure we've done that yet. Just for those who may not know, do you want to go through that? Because you've got a dynamic pelvis.
Yeah, of
Mine doesn't.
course. Yeah.
I say mine doesn't move that well. Mine moves okay. My Kelly's
It's a
just.
bit heavier. Yeah, so basically what you have is you have what's called pelvic neutral. So neutral essentially means you're not forward or back or side to side, you're just in the center. So the classical way in which we define neutral, there's typically one way, but there's two ways. It's essentially if someone has a horizontal line going from the front of the pelvis to the back of the pelvis, that may be defined as neutral. Now, just for those of you who know a bit more about anatomy, essentially it's from the anterior superior iliac spine, so the hip bone. If you have a horizontal line going to the posterior superior iliac spine, that's essentially a bony protrusion at the back of the pelvis, that would be classified as neutral. Sometimes some studies also define neutral as a vertical line from the hip bone going down to the pubic region as well. So if someone stands or sits in that position, then that would be classified as a neutral pelvis. So if someone, for example, doesn't have that orientation, so let's say that they are tilted more forward, what that would do is that would put the hip bone lower down relative to the PSIS. And so then that would be classified as an anterior tilt. And then vice versa, if the hip bone is higher, so let's say we tuck the tailbone, then that will be classified as a posterior pelvic tilt. So the classical way essentially is any deviation from the horizontal and vertical line marks were either anteriorly tilted forward or were posteriorly tilted backwards. So anything you want to add to that, Rach?
No, I think where we're going with this conversation, just adding into the mix, that change outside of the natural or neutral posture will obviously impact in an ascending biomechanical way through the lower spine, which is what we're talking about here. So when we have an anterior tilt and the bones at the front of the hips are lower, the ASIs are lower than the PSIS, then the lower spine will go into more of a lordotic curve, so it'll be more arched.
Mm.
But when we go the other way out of neutral and the PSIS are lower than the ASIS, the lumbar spine will, you would assume, look flatter. And that's
Mhm.
the example that I was suggesting I've seen more of in people that I've seen with back pain who
Mm.
are maybe not in what you deem a normal posture or position.
Mm.
They're more likely to have a flatter back and a posterior tilt. But that's
Mm.
just in my limited experience. I don't know about how, what have you found, Tom?
It's funny actually. I've actually had a really similar experience.
Okay.
So I'm the same as you, Rach. I don't tend to. I find posture interesting. I think it's something that I definitely am at least aware of, but it's by no means like the final metric, or something that I'm putting as like this has to change for this person to improve, or reach their goal in any way. It really depends on what the goal is. But I think what one memory I've got is I were working with this ballet dancer years ago and she was dealing with back pain. And I gave her a full biomechanical assessment, and she was actually in pretty good nick. We were doing a few things, and she was moving really well. And it was interesting. Like the goal was not to get out of pain. The goal was to improve the movements that she was feeling limited in. But she kept coming back to this lower back discomfort. And I remember one time just watching her stand, and she was really, really tucked, like noticeably in a posterior tilt.
Yeah.
And especially in ballet, the aesthetical requirements or expectations typically in ballet is to be in a posterior tilt. And there's many reasons for that. It makes the pelvis look more open. It kind of makes the spine look longer when they're doing a plie. But functionally, it doesn't make a lot of sense. But they do it, and they put a lot of force through their pelvis while they're doing that as well. And I did just mention, I asked her, well, are you tilting your pelvis backwards? And she said, yes, I'm tucking it. And I just asked her to not tuck it. And as soon as she didn't tuck it, her back pain pretty much went away. And that was quite like it was bizarre. Because again, I wasn't coming from the framework of that's going to correct your back pain. We weren't even looking at back pain, but this is what happened in practice. And it's interesting because for her, it was actually more emotional. She wasn't getting upset, but I could tell that she has this image of how she's supposed to stand, and that's been obviously taught through her dance career. And then suddenly I'm saying, well, you don't need to stand like that. And then literally when she doesn't, the pain does dissipate. So it was an interesting conversation because I could tell she almost wasn't happy about it in a funny way, which I think also it does tie into this emotional aspect of posture and what your expectations are and how you should stand and how that all kind of comes together into the human experience. So yeah, it's funny. So you know, like you, I'm normally interested in movement, and if I think there's a postural pattern that is preventing someone from moving freely, if their head's really far forward and they can't get their arms so easily over their head, then it would be silly to not, at least on some level, address the head. But that was a really specific example of someone was really tucked, and then when they were not tucked, their lower back pain seemed to go away. So that was really interesting. What about with what you've read, Rachel? Because I know obviously you're an avid studier in your own right. Obviously, we educate students, so we want to make sure that we're relatively up to date with different topics. And what's been your interpretation of the studies that you've read around lower back pain, pelvic tilt, and what's your current understanding of that connection or lack thereof?
That there is a lack, I think, and I think we've got to again contextualize what studies are showing and what they're looking at, and that's really important to understand, because trying to fix a posture is probably not the best way around it. It's understanding the functionality of that human being, what they're trying to achieve, and where's their start point, where are they trying to get to. As you've said, is the goal to reduce pain, or is it function? Inevitably, in our world, you improve the function, the pain can often dissipate.
Mm,
But
mm,
there's a very weak link between specifically a posture of the pelvis and low back pain. And I think where studies have linked it is where they've seen an anterior tilt and then addressed gluteal function, the back pain has improved. It's not necessarily the position of the pelvis that changed the back pain, it was the functionality of the muscles around it. So again, it's understanding what the studies are actually looking at. Is it causality, is it correlation, to really identify the link between pelvic posture, um,
mm.
dissipation or not of back pain, and what's been done about it. So I think that's what's been tenuous through the studies I've looked at. I don't know what
Yeah.
you found.
Yeah, I think it's really interesting because it's I think one glaring issue which can come in any study, it's not even about posture, but in any study can be just confirmation bias or being too reductionist in what you think is causing something or what fixes something as well. Just because someone presents with an anterior pelvic tilt and they have back pain doesn't mean that thus the pelvic tilt is causing their back pain. And I think too, there's almost always a sample size issue with these things, like small sample size, or it's too specific a demographic. Because obviously if you look at other demographics like the pregnancy demographic, their pelvis goes through a lot of changes, and so that might be in my mind that can be a demographic where maybe there is a stronger connection. But there's other things going on than just the pelvis that's changing, obviously, as well. So I think one of the main things is like pain is a multifactorial issue. So there's an emotional and sensory aspect to pain. And so, yes, biomechanics can have an impact on that. So I do think that biomechanics can impact your sensory perception on a level if you're restricted neurally, which can impact your sensory function, then that may have an impact on your experience of how you move or how you feel. And so I think the biggest issue is when we're being too reductionist. So this person has an anterior pelvic tilt, they have back pain. That means if we correct the correct quote unquote the pelvis, their back pain goes away. One thing I've noticed is there's a I forget when the study came out, but there's a good study or there's a couple of them that talk about how that you can't even change pelvic tilt or yeah pelvic tilt through exercise. And I've referenced this study a few times in certain social media posts because what I find really interesting is how what you can experience is different to what the science may say. And doesn't mean that the studies are always correct because there's limitations in those too. Because I've had the experience very much so where I'm not bothered about someone's pelvic rotation, whether it's forward or back, neutral, that doesn't really concern me. We're working with the individual. And I have noticed that, oh yeah, like if we do this with their feet, their pelvis changes alignment. And then if they work on their feet for quite a while, that alignment seems to maintain that new alignment. So my experience in practice in the clinic or in the studio compared to what studies say where you can't change pelvic alignment is obviously not marrying up.
Yeah.
And I think one of the issues that a lot of I used to have this issue is then I'd go like, oh no, I don't know what I'm talking about or I'm wrong. And I think it's actually okay to acknowledge research and be like, well, the research says this, my experience says this, and this is currently where I'm at with it, rather than either trying to ignore the research doesn't say what you think, or always get second guessing yourself because the paper that came out 20 years ago said that that's not the way it is. So I think when it comes to does anterior pelvic tilt cause back pain, just like you said, there's studies to suggest that it does. but there's a lot of limitations in those studies. And then there are quite big studies that do not show a correlation at all. And even to the point where anterior pelvic tilt is the prevailing posture in the demographic who don't have back pain. So I think it's something roughly like 80%, isn't it, of people that don't have any back pain, so asymptomatic individuals, present with an anterior pelvic tilt. So it may even be the most prevailing posture that we have in the population. Neutral might be more the quote unquote abnormality in terms of if you're actually in neutral most of the time.
Yeah, as you were speaking then, I was visualizing because we we talk about sort of alignment and looking at people move. And I love watching the human body. I adore watching dancers, gymnasts, Olympic lifters, runners, but not for perfect positioning necessarily. In dance, to some degree, yes, as you've said, there's an aesthetic pleasure to hitting lines, and they're all the same in a can or whatever it is.
Mm.
But at the same time, you think about a gymnast. So a gymnast, they very often have an excessive lordose because in their sport, when
Mm.
you talk about the ballerina is very much in a posterior tilt,
Mm.
that straight spine. Gymnasts will be the opposite way. They'll be super
Yeah.
extended. So in some ways, looking at movement choices, some movement choices may actually have a degradation of your perfect posture. But if
Mm.
that brings you so much joy and you can do that feeling well and moving well, then great. The other side is thinking one of my personal nerdy joys is watching Olympic lifting, and you take a small Asian Oriental Olympic lifter in an overhead squat, and a long, tall Afro-Caribbean American, with long limbs. And they're just
Mm.
the difference in the way they catch the receive position, their
Mm.
posture under load is I find that quite fascinating. And I think the link between alignment and pain, as you've said, pain is just far too complex. There
Mhm.
has to be a correlation. There is obviously a correlation to some degree. If an
Mhm.
Olympic lifter catches a really heavy bar overhead out of alignment, they're going to hurt themselves
Yeah.
because that weight's
Yeah.
down over the body. If the
Yeah.
joints are not stacked in an effective and efficient not position to catch that heavy weight, they will
Mm.
damage something. So there's that
Mm.
aspect to it. However, in general life, if you fall over, have an accident, you're
Mhm.
not going to land with your knee in perfect position, with
Mhm.
your body upright, and the thigh up parallel.
Yeah.
You're just going to fall
Yeah.
into a position. So it's always then about what am I doing with this person or my body or whoever is listening to this or watching this back? What's the goal? Where am I at?
Mhm.
What's the risk versus reward? How much does
Mm.
that alignment matter? How much do I coach it? And what
Mm.
emphasis do I put on it? And what assessments am I using? Because you and I, as
Yeah.
coaches, use alignment in our testing process,
Yeah.
but
Mhm.
it's the value we put on it and the interpretation of it that I think people can often misunderstand. So leg
Yeah.
length, I measure, but I don't care about leg length because it might be
Mm.
I can't change it if somebody's got a
Mhm.
longer femur from birth.
Mhm.
It's a benchmark of movement quality and any changes in movement over time. If it never changes, I don't worry about it. So if
Mm.
somebody comes in
Mm.
with an anterior pelvic tilt, I might notice it, comment, make a note, but I'm not worried about it. I'm going to improve the functionality. And
Mm.
I think we've spoken about this quite a bit.
Mm.
Force trumps alignment every time for me. So
Yeah.
it's the
Yeah.
ability to produce
Yeah.
force, whether it's just walking and or hitting those certain lines. That
Mm.
really it is what I'm thinking rather than I need to get the legs into the same length. Does that make sense?
100%. I think too, with the example of like the powerlifting where you're dealing with such big forces, I think what we're saying here is very much when you're dealing with huge loads, biomechanics becomes much more relevant in terms of how can we get that person's body into the best position so they can generate force safely
Yeah.
and efficiently. So it's like yes, alignment is relevant. It's relevant within the context of the individual and what forces they have to manage in that moment. But then when we're talking about very low forces like standing, or again, I'm from the Pilates world, so I'm probably going to get some hate for this, but in Pilates we do deal with relatively low loads, even in the studio context with the springs, comparatively to other exercise modalities. We're dealing with low loads, and so in that sense, you can argue, well, even though we talk about a lot about alignment in Pilates, that may be a context where actually it's a safer context to explore other alignments because the loads are not as big there. And I think too, like one thing, going back even to the research, one thing I always find interesting in the back pain conversation is, because if I wanted, I've read these studies. If I wanted to find studies that said alignment training helps people get out of back pain, those studies do exist. So we know that if someone focuses on spinal pelvic neutral and they do like a 12-week exercise program, they're going to be in a better place than they were at the start in terms of their pain. We also know, though, that if you do general exercise, which is non-specific, like going for a walk a few times a week for 12 weeks, and there's no focus on alignment, those people do just as well in the long term. And so you have these two opposing ideas that create the same outcome at the end, which is one is alignment, one's not. They both help people get out of back pain. So I think for the personal trainers or Pilates teachers that are listening, I think one thing to also bear in mind is although Rachel and I are not saying that there is a perfect alignment and we're not saying that you have to quote unquote correct an anterior pelvic tilt, if you like teaching alignment and your clients enjoy that and you've had your own experience of that benefiting your client's health, then keep doing it. But it's just also zooming out and appreciating that there's so many ways you can win with your clients. And it doesn't mean that we all have to be in this Goldilocks zone. And then that's when you're quote unquote safe. Does that make sense, Rach?
It does, and I think it brings about the idea that if you always train everybody in the same way, you are going to hit a sticking point at some point. You bring in typical, atypical differences in anatomy. So the directional position of the acetabulum of the, and where the pelvis, so your kind of femoral versions, your coxovalvaras that we speak about quite a bit,
Mm.
does that influence, and I don't know, by the way, I've not seen a study yet, does that correlate to somebody being more likely to anterior tilt? If so, and I think this is
Mm.
back to the research. Research, the more you read research, it's really important. It's really informing. And I know Tom is like me, we really enjoy reading research, but you often realize how flawed it is, in particular when it comes to the human body, I think, in kind of biomechanical studies,
Mm.
because there's never a common start point.
Mm.
There is never that I've seen, a group of subjects that all have exactly the same length femurs, exactly the
Yeah.
same pelvic alignment, exactly the same muscle tone. They've all got mobile nervous systems. None of them have got a functional leg length discrepancy.
Yeah. Yeah.
They've
Yeah.
all got mobile quadratus lumborum. The start point is never the same. So in terms of testing force production through the knee, symptoms, it becomes a challenge to be that clear on, well, that must be causing that, because the common start point is really probably
Mm.
impossible to have on a
I
big.
agree. I agree. I mean, there's not even. Sorry to interrupt, but I love that term "common start point." That I need to remember that. I really like that because there's not even a common start point necessarily in the same person from right to left either.
Exactly.
Um, which is like so. Like you say, Rachel, I think when you start to learn more about anatomy and variability in bony anatomy, especially, then when you go back and read that paper that showed, yes, anterior pelvic tilt is measured this way, and this is the importance of it, but then you're like, well, do they account for the fact that there's other research to show that the pelvic bone on the right side, where the hip bone is, can be like 11 degrees higher than the one on the left side. So then when we look at overall measurements, how do we know that they've accounted for that? And how does that impact their measurement accuracy or reliability?
Yeah.
Yeah, which is like it's a whole thing, isn't it?
Oh, no, 100%. And I've seen in a cadaver lab an ASIS that measures 26 mil on one side, and the same cadaver on the other side, the ASIS only measured 14 mil. So,
Wow.
so how
Yeah.
do you measure the tilt? Plus,
Yeah.
with dynamic, that's constantly
Yeah.
changing. So, and
Mm.
I think just for the people watching and listening back, we've gone into quite a bit of detail. I know we like to simplify, but I'm mindful of anybody new in movement or end users, so clients, typical clients, who are just listening in. We need to start from a simplistic basis. So alignment is a good start point. If you're coaching movement, you're new to coaching movement, starting with coaching alignment is a good thing. But I think being rigid in it is where you might hit problems. That's when I first trained
Mm.
as a level 2 gym instructor, and I just loved all the sort of abduction, adduction, flexion, extension, alignment. I was really good at coaching it. I was really good at getting
Mm.
people into positions to a point. And then the more bodies I worked with, I thought, actually, I'm not
Mm.
that good at this. So
Yeah.
not everyone can
Yeah.
get in that position. And it's
Mm.
understanding that the development of your knowledge and understanding of the variations in the body, see that as a good thing. I get excited when we talk about anomalies and atypical
Mm.
presence. I'm like, this is amazing
Yeah.
how different we all are, and yet, we all function to some degree, and our job is literally just. I think where my talk on Saturday about can you do yoga wrong, it just really boils all the way down to my job is to help you enjoy being in your own body, and
Hmm.
that's however that happens. So I don't think we should be afraid of using alignment as you've just highlighted. I think that's important, particularly when you're new to coaching movement, but it's having
Yeah.
an open mind.
Definitely, yeah. And I think like then going back to what we do as coaches, biomechanics coaches, it's going back to this idea of function. So, in my experience, like you just said, our job is to help people feel better in their bodies because if they do, then they will typically move their bodies more, and then that's really good for the population. And I think how we do that as movement practitioners, whatever your modality is we help people to move more freely. And in my personal view is good alignment is just the ability to move through all of the planes of motion freely. Even, not even necessarily range, because that is also down to your own anatomy to a degree. But certainly, I think a healthy pelvis should be able to move forward, move back, rotate side to side, and then even have, as you were gesturing with your hands, its ability to even twist a little bit as you walk. And in my view, if someone can do that, then they have good dynamic alignment, where they're able to dynamically adjust to the exercise, the posture, the forces they're putting through their body, rather than having this, I hate to say the term really, but almost outdated view of like it's like you have to be like a statue and you have to hold still. Because even your initial practical example of swaying back and forth and feeling the tension, one thing that listeners can do in their own time is if you, a fun exercise is to stand up and close your eyes and try to not move a muscle for like as long as you can. And you'll notice it's impossible. So we have a thing built into our neurology called postural sway. And there's two reasons why you have it. One reason is because if you were able to be in neutral all the time, you'd be exhausted because you're using the same motor neurons constantly to maintain. Yeah, like a statue. You'd simply just burn out. So one thing is you always have a bit of dynamic alignment, so you don't overwork a particular muscle fiber or whatever, like collagen fiber. But then the other one is, we've evolved for very adaptable movement. So, having a sway to you actually always primes your physiology for movement on a level. So it's almost like if we're always telling people what not to move or what to keep still, there may be some efficacy to that in the short term. But as you say, Rach, when you're working with more people, I think we have to be a bit more adaptable with what we think good alignment is.
Yeah, I think I would add into your definition of moving through all planes freely with stability and control.
Mm.
I'd probably add in there because that's where I'm thinking of dancers and gymnasts again, can sometimes having excessive movement, moving freely, can be as detrimental as having limited flexibility across a joint or a soft tissue. So it's within a certain parameter of freedom of movement, but with stability and control, which comes down to all the three subsystems: the joint mobility, flexibility of the soft tissue, but also then
Mm.
neural input, that software of the body, which is the central nervous system. But I just want to I know we're coming towards the end of this. I just wanted to pick on something, if I may, Tom.
Yeah, of course.
And that's what you mentioned about pain, because we're talking about posture and pain. And I think we've talked a lot about posture and alignment. And just to touch
Hmm.
again on the pain perspective for those listening, if there's anybody in the audience who is experiencing pain, works with people in pain, the real complex nature of pain and pain science, and what we're starting to realize about how complex pain is. And you mentioned emotion and, more than just physicality. I
Hmm.
think from our perspective again, and how I just wanted to mention about, if we talk about back pain, could be
Hmm.
a symptom of something that is actually remote from the back, right?
Yeah.
So if we think about, I don't know, tension in a hamstring, a limitation there that's tethering the nerve in the hamstring could actually present as back pain, for example.
Mm.
And so again, keeping an open mind to the concept of pelvic posture linking to back pain. We've talked about the
Mhm.
posture thing. We've had that back and forth, I think. But just to
Mm.
bring that about as well is how complex pain science is, right?
Yeah, of course. Yeah. And I think that's why, again, it's not to throw everything out of the bathtub, right? Whatever the metaphor is, but it's like, pain is multifactorial for sure. And I think that's been a really good message the past maybe 10 to 15 years as a more popular message in our industry, in the physical therapy industry, but also in the movement industry. And I think sometimes that can, unfortunately, we take away the biological aspect of pain, and so it's all about somatics or the emotion, and then that's obviously massive, and there's loads of research for that. But like you say, the body is an integrated system, and we are working with an organism, a whole person, and so when it comes to someone's back pain or any sort of pain, and we say, well, there's no connection to posture and back pain. Well, there is a connection, though, to someone's emotional state and their posture. And if we're saying that emotions or psychology can have an impact on someone's, pain experience, I think it's an interesting connection. So although maybe changing the posture itself doesn't improve the pain, I do find that when someone is feeling better and they're feeling more confident or more motivated, that tends to be expressed in their posture, and that might change their pelvis on a level. So it's not to say that that's the primary cause. I think with pain, there's so many drivers to pain. It's how many stresses that person can tolerate until their nervous system perceives a threat. Um, but I think as practitioners, although we have to always be aware of our scope of practice, if we are helping someone in discomfort, I think there's so many ways we can help that person. And I think part of that is, can we get the pelvis to move more freely? Does it change the posture? Probably does. Great. But it's really about, like you say, with control and stability, can we move freely through all the different planes of motion? And how does that impact, if it does, their pain experience? And I think unless there's something more medical going on, which I know if that's the case with you and I, Rach, we tend to refer it anyway. But for people that we tend to work with, that tends to be quite a game changer for a lot of people if their nerves are freer to slide and move, and if their muscles can contract with more ease, and their joints are able to move more freely. But I think it's mainly keeping an open mind, isn't it? When it comes to these things. I remember I'll finish on this little story. I remember years ago, even longer than the dancer, had this woman who like really, really bad back pain, like really, really bad. And she had to the point where she actually moved cities because she couldn't work anymore at her business, and she couldn't socialize so much because she was so afraid of the pain, like falling down, not being able to move, really, really bad. Medically totally cleared, nothing wrong with her. MRI scan perfect. So she was working with me and a bunch of other people to help her with her pain symptoms. My job really was to get her to move and exercise. It wasn't to help with her pain. But I was using the biomechanics coach system to help with moving the shoulders, the spine, and the hips more freely. And anyway, I remember one time she was an avid golf fan, loved golf, and she didn't want to play golf because she was so afraid that maybe she had a back pain episode the golf course. And so she didn't want to get anywhere near the golf course in case she couldn't, like, the embarrassment of like having to, be carried back to the club, after having like a back pain problem. So anyway, I flippantly said one day, can you drive with this pain? And she said yes. So she couldn't walk, but she could drive. And I said, well, if you had a back pain episode, couldn't you just get a buggy and then drive back to your car, and then you could drive home, and no one really has to know that you're experiencing this issue. And that became like a big game changer for her. I don't take a lot of credit for it because it was such a flippant comment, like I just said it, and she was working with other people. There's many other things going on, but she did actually then play some golf later. And for her, she was only in a certain level of discomfort that was brilliant. So she could play golf fully, played all, I think, whatever holes there are, 20 holes, whatever it is. And then she kept moving, and she actually got a lot better over time. But that was like a belief thing or mindset shift that sometimes just comes from a conversation, and it's not like a diagnosis or anything. So yeah, I think it always comes back to working with the individual, if that makes sense,
And I
right?
think that was all I wanted to sort of really pull in is pain or pain reduction is often the biggest motivator for
Yeah,
clients, for individuals. They're actually probably less bothered about the position of their pelvis. They're not really
yeah,
bothered about that.
yeah,
My back hurts. So it is an
yeah.
important factor, isn't it? And so subjective and multifaceted that we can't just
Mm.
link it to a pelvic posture, which is, I guess, how we answer our question, right?
Exactly. Exactly. Thank you, Rachel. Well, we're going to leave it there today, guys. I want to let you know that so we're going to be doing another chat cast soon, and it will be on the sacroiliac joint. So we're going to be talking about the anatomy, the biomechanics, and maybe some myth busting around the SIJ. So look out for that soon. And also to let you know that Rachel and I are going to be doing a live workshop on the, I'm getting the dates up now so don't get the wrong date, will be on the 11th of November, which is a Tuesday. So we'll let you know more about that in the future. But if you find kind of our way of problem solving interesting, and you want to see like real life scenarios and how we might work with a particular person, or with particular info in mind, like their medical information, that'll be a really, really good workshop around the pelvis that we're going to be doing in November. So we'll let you know more about that when we get closer to that date. Anything you want to sign off with, Rach, before we go
No,
today?
we can put a link to that into this video. So
Mm.
when we put this live onto YouTube, if you scroll down, you'll be able to see where you can actually purchase that live webinar. I actually thought it was December, but we'll put it into the show
It
notes.
may be December. You know what? It may be.
I thought, but it might all change. Who knows? It will be in the show notes. Don't
Yeah.
worry. Thanks, Tom.
Thanks, Rach.
Take care.
Well, thanks again for listening, guys, and watching, and we will see you soon. And have a great day. Bye, guys.